Hello, everyone. I am so honored to have your invitation to speak at the Society of Critical Care Medicine. I'm a pediatric critical care physician. I was a member of the society for so many years and enjoyed every moment of it and really cherished the mentorship that so many of you gave to me. I want to especially say hello to so many good friends and colleagues, Jerry Zimmerman, Michelle Moss, Renee Manwarren, who are now so prominent in the society's leadership. In my role now as the Assistant Secretary for Health, I bring all the experience that I learned in critical care medicine to the public health challenges of our time. And although it doesn't seem that they're necessarily a natural marriage, they really are. And so for the next few minutes, I want to talk to you about the changing spectrum, the changing continuum of healthcare in our country, some of the challenges we face, and how we can work together to solve them. We can all feel very proud of the advances in longevity that have occurred in the United States over the past 100 years. Our life expectancy has increased dramatically during that time, only interrupted by the great health crises of our world, for example, the 1918 pandemic influenza outbreak. We have made strides in influenza and pneumonia, enteric diseases, stroke, cardiovascular disease, tuberculosis, and very significantly accidents, both from their prevention, but also from the tremendous treatment and advances in trauma care that members of this society have pioneered. Yet despite all of these advances, we face tremendous health challenges in the 21st century. I start with cost, not because cost is the most important factor, but because it does give us a context. We spend almost 18% of our gross national product, $3.3 trillion a year on health care. That's expected to rise to $5.7 trillion by 2026. And although that's a lot of money, if we were leading the world in healthcare, in longevity, survival, quality of life, it would be one thing, but we're not. Among our peer countries in the OECD nations, we rank 28th in life expectancy out of 36, 33rd in infant mortality, 32nd in our suicide rate, and very alarmingly, we had life expectancy decreases in both 2015 and 2017. We are the first generation in over 2 centuries that face the realistic possibility that our children will live less long and less quality of lives than we do, and that's simply unacceptable. Look at some of the other statistics. We have the highest number of sexually transmitted infections in our history, over 2 million, and we know what that does now, not only to antimicrobial resistance, but also fertility and risks for future cancer. We are at enhanced risk from pandemic influenza because of the closeness of the world, emerging infectious diseases, and antimicrobial resistance. And of course, we all, as intensivists, understand the threats of biological weapons or potentially chemical, radiological, or nuclear weapons that could be inflicted on the United States by rogue states. When we look at the overall health of our population, there are many different statistics we can look at. I like this one because it is so dramatic and it really tells the point that approximately 71% of our 34 million 17 to 24-year-olds would fail to qualify to enlist in the military if they tried. 71% and rising. Why is that? Because of physical fitness and obesity, but also because of drug abuse and a lack of education. Drug overdoses are something I'm sure are incredibly familiar to all of you. We lost over 70,000 Americans in 2017, the majority of those from opioid overdoses, increasingly now synthetic opioids like fentanyl that are illicitly imported into the United States, primarily from China. Well, as intensivists, it's not all doom and gloom. We know that we can make a difference even in the most dire situations. And because of the training that I've had and all the work that we've done together, I am truly blessed and honored to have the opportunity to try to make a difference as the Assistant Secretary, as a Senior Advisor for Opioids, along with the Surgeon General of the United States leading the Commission Corps of the United States Public Health Service, and service at the World Health Organization. Now, how do these all fit together? As the Assistant Secretary, my main goal is to transform the current sick care system into a health promoting system. Indeed, I look back on my time where I took care of a child with measles on ECMO for a month because of respiratory failure and pneumonia, when we could have had that child immunized and avoided that altogether. We need to work in health promotion so that the only people who come into our ICUs are those who have dreaded diseases, trauma, needing of transplant or surgery, things that we can't prevent with today's technology and methods. As the opioid policy advisor, we are pioneering in transforming the current system into a whole of society holistic approach that emphasizes the public health nature of the crisis and the holistic needs in recovery. The Commission Corps will be an agent of change for public health in the future. I wish I could spend more time about that, talking about how we will change the map on health disparities, change the map on infectious diseases, change the map for health opportunities across the country. And finally, the world can benefit from many of the things that we have pioneered, primarily primary care. Primary care is a mechanism to raise the health status of the entire world, increase global health security, and provide a first line of defense against emerging infections such as Ebola or other diseases. When I sat on the other side where you sat, I really thought of the federal government interacting mostly with grants from NIH, because that's what we so work for. On this side, I would ask you to think about some other opportunities we have, because there are many other opportunities, either in guidelines that we publish. My office published the physical activity guidelines. We published the nutrition guidelines. We're determining the national HIV, hepatitis strategy, etc. So there are many guidelines that could change behavior. But the box on the bottom is something I've really been focusing on much more, and that is reimbursement in workforce. If we want to change the system, we owe it to our clinicians and to everyone to make sure that the reimbursement is commensurate with the value of those services, so that we reward for health, we reward for outcomes, we make sure that clinicians have the freedom to spend that money on what's best for their patients. When we look at the whole spectrum, we know that medical care is only a small portion of overall health outcomes, which is why I know that I have been, and many of you are, working in your communities to change health behaviors, whether that's wearing seatbelts or putting your child in a car seat, or social and economic factors to improve education, or the physical environment that is so important. We also need a few internet moments. This was actually the first diagram of the internet in 1969 at the agency ARPA, which became DARPA, where I worked for 4.5 years. I think we're at the precipice of internet moments within our system, and I'll talk to you a couple of them that we're working on. First of all, we're developing orthogonal technologies and paradigms for the most costly medical issues. For example, end-stage renal disease, which will be a topic you'll hear about much more in the near future. Technologies and approaches that allow for more advanced care out of hospital settings. Again, transforming many of the things you do to different environments. Socio-behavioral approaches to transform behavior to promote a health-promoting system. Leveraging big data and social media for public health and not just for sales of products. We need to stop the epidemics within our control, and I would say HIV, HCV, and HPV are those. Emphasizing genetic cures, cell therapies, and immunotherapies because they provide long-lasting cures and long-lasting survival with high quality of life. Neurodegeneration, we need a new paradigm. We are clearly failing to understand all the diseases that cause neurodegeneration, so I think we need broader thoughts. And finally, global health security. How do we protect everyone by building indigenous capacity? Last couple of thoughts before I leave you to your meeting. The President announced our initiative at the State of the Union to end the HIV epidemic in the United States. I will be on the road along with many of our colleagues urging all of you to participate in this because we have the tools, the technologies, and the techniques to drive down that 40,000 new cases a year by 90% within 10 years, and I do believe by 75% within 5 years. And we will be focusing on hotspot counties first. If you represent a population under those dots, you will be hearing from us very soon. And finally, as an intensivist, I have a little broader view of public health. It's certainly about nutrition and exercise, but it's also about CPR, something that all of us have done and I care deeply about. We all know that there are 350,000 out-of-hospital cases every single year, but only 10% survive to hospital discharge. We all know that an extra 10 or 15% could likely be saved with meaningful long-term survival just by adequate CPR. So we want to change that. And it's a tremendous source of health disparities, with people of color having the opportunity to receive CPR only about 50% as much as whites within our country. So we will have a major effort to expand the CARES registry for CPR, not just to collect data, but to engage in real improved outcomes through quality measures and financial incentive development. I again want to thank you for the opportunity to visit with you this morning. Again, I would love to see you all in the future. If you're ever in DC, we'd love to meet and get your input, and I look forward to tackling the most important health problems of our country with you in the upcoming years. Thank you very much.